We can start with the first talk by Dr. Shiva Kumar from Chennai on basics of hemodynamic assessment. Dr. Shiva, please.
Thanks for inviting me. So basically, what I will do is this is primarily intended for all the younger generation developing cardiologists, both adult and pediatric. I'm going to divide it into 4 small parts to understand what is first a cardiac output. Cardiac output is basically defined as the quantity of blood that is delivered to the systemic circulation per unit time. We have to understand that this is the amount of blood that goes through the systemic capillary bed, and it is not the amount of blood that goes out through the aortic valve. That we need to be clear about. So let me just clarify on this. For example, in a patient who is having a left to right shunting PDA, the aortic valve is actually carrying not only the systemic outflow, but also the blood that is coming back through the ductus. So it actually is the QP. So we should understand that the amount of blood that goes through the aortic valve is not QS, and it is the amount of blood that goes through systemic capillary bed. I'll introduce one point here. If suppose, let us assume in a pulmonary AV malformation, we are finding what is the QP. So it is the amount of blood that goes through the pulmonary capillary bed. So how will you calculate now? Arteriovenous difference has to be PV minus PA. So in that case, the PV actually will be desaturated because of the pulmonary AV malformation. We should not take the desaturated value. We should assume that it is normal at 100% and take 100 minus PA, and that is the amount that is calculated as QP. So what I want to point out is cardiac output is the amount of blood that goes through the systemic capillary bed, and QP is the amount that goes through the pulmonary capillary bed. The formula is oxygen consumption divided by arteriovenous oxygen difference. So oxygen consumption, how do we calculate? Previous methods were polarographic method and Douglas-Bag method, but now most of the research labs use what is called respiratory mass spectrometry, which is fairly very accurate. But practically many of us will use nomograms from Lafarge and Lundell. Let's understand what it is. Respiratory mass spectrometry is sampling a small amount of the expired air which goes through a dispersion chamber and ionization chamber, and it immediately tells what is the quantity of oxygen that is present in a fraction of air that is taken out from the expired air. So it precisely tells you what is the amount of oxygen that is coming out in the expired air, and from it you will be able to calculate what is the amount of volume of oxygen that is consumed. However, in order for the equipment to be very soundproof, we need to have a complete anesthesia, sedation with mechanical ventilation, so that there are no leaks at all in any of the system. And if you put a patient on general anesthesia, sedation and mechanical ventilation, automatically the cardiopulmonary work reduces, and the VO2 also reduces by 20 to 30%. So even though it is accurate, the result that we are getting is not real value. It will be an underestimate. Doing it without any sedation, a respiratory mass spectrometry includes lots of errors, and the value of VO2 that we get will be very erratic. Recommendation by the Pulmonary Vascular Research Committee says that the cardiac catheterization ideally should be done when the patient is spontaneously breathing, either awake or moderately sedated. So obviously we cannot consider a respiratory mass spectrometry to be the ideal method. So for practical purposes, the Lafarge graph is the one that is going to be useful. Lafarge graph was actually derived after a study from 61 to 67 at Boston Children's Hospital on close to about 900 patients by the older Douglas-Bag method in patients who were between 3 to 40 years, and they arrived at this charts. And obviously none of the patients were less than 3 years, so it is not validated. So how do the present Lafarge formula? It is actually a derived formula. So based on the derivation, we look at a constant minus a constant into logarithm of the age, which is subtracted. So since the logarithm of the age is subtracted from the constant, the smaller and smaller the age of the patient, the more and more will be the VO2. So the estimated VO2 by Lafarge method in a very tiny infant will be quite high. Contrary to what we might think, actually a small baby will have a relatively lesser amount of VO2. So that is the difference between the estimated VO2 and the true measured VO2. And that is one of the fallacy of this Lafarge formula. So in order to avoid this logarithm in the calculation, the next method is called Lundell's formula, which is based only on height, weight, and some constants. So Lundell is basically a second type of formula that is arrived in Sweden from around 504 patients. And this avoids completely all the exponential and log formula. But majority of us, we still use the Lafarge equations only. Suppose if you don't have any of those equations in hand and directly you want to make some calculations, the average VO2 of a normal human being is 125 plus or minus 25 ml per minute per meter squared body surface area. So when I am telling plus or minus 25, add a little bit more for a male and subtract a little bit for the female, add a little bit more for a younger child, subtract a little bit for a very older person. And if the patient is sedated, subtract a little bit. If the patient is unsedated and active, add a little bit. So on an average, in and around 125. So now we have come to what is the oxygen consumption. The second one is arteriovenous oxygen difference. Arteriovenous oxygen difference is calculated by what is the oxygen carrying capacity into the percentage saturation. Hemoglobin is one derivative that is easily derived from the labs. Now, how is the percentage saturation being calculated? Percentage saturation is currently calculated in all the cath labs by what is called as a co-oximeter, where the blood, a combination of red and infrared light goes through a chamber through which the blood is present, and depending on the concentration of oxyhemoglobin and deoxyhemoglobin, there is going to be a variable absorption, and depending on the absorption, we are going to tell what is the percentage of the oxyhemoglobin and what is the percentage of deoxyhemoglobin. We know that deoxyhemoglobin is primarily taken up by red light and oxyhemoglobin is primarily taken up by infrared light. And based on this difference between the input light to the output light intensity, automatically the machine calculates what is going to be the saturation, percentage saturation. And based on that, we are going to find out what is the oxygen content. Whenever the patient is taking inspiring oxygen, we have to take PO2 also into consideration. And so in that case, ABG is used. In the previous generation machines, like 10 to 15 years before, saturation was actually derived from the ABG. But now today, all the current machines are called co-oximeters. They work on cartridges. They separately assess saturation and PO2, and the saturation that is calculated is not derived from the PO2 in the present generation co-oximeters. So now we have understood what is cardiac output. The second one, how to understand, we will understand how a pressure is being recorded. I'll show one pressure trace. This is a typical example of a right atrial pressure trace where the right atria is showing tall A waves and then a deep X descent, a small V wave and a small Y descent. There is a mean line that is coming here, which is basically the area under the curve. The area under the curve is calculated by every individual machine depending on whether it is a beat to beat calculation or whether it is under the entire page. So here you are able to understand that this whole page, the RA mean is around 8 to 8.5 millimeters of mercury. This is 10 scale. Now, when you carefully look at the trace, during inspiration, there is a fall, during expiration, there is an increase. But since this mean is being averaged over the entire page, there is not too much of change. Now, this is a very complex periodic fluctuation in the pressure. So how is it arrived? We know that it is through a transducer. The transducer carries a miniature circuitry, which is based on what is called as Wheatstone bridge principle, a series of resistors behind this chamber. So if there is a blood that is, the fluid is pushed in the diaphragm now pushes this Wheatstone bridge, the resistors closer or pulls it away. So there is going to be a change in the resistor's length, either lengthening or shortening. That is going to change the resistance. And when the resistance is changed, the input voltage and the output voltage will be different. Now comes three terminologies. What is balancing, what is zeroing, what is calibration. Now, whenever a transducer is exposed to no cardiac chamber, what should actually be our output? Output should be zero. If the output is zero, then the pressure that is recorded in the pressure transducer will show as 0 millimeters of mercury. And that is what we want. But sometimes it may give 1 or 2 or 5 or 6. So we have to add a variable resistance in G1, G2, G3, G4 in order to get the output 0. And that addition is called as balancing. Balancing is an automatic machine created an alteration in the resistances in order to get the final output 0. So once it is 0, the technician will tell you, sir, it is balanced. Then you move the transducer up and down till the exit that is going towards the air is at mid-chest level. And once this is at mid-chest level, then you calibrate the machine that the output is 0 at that 0. So now we are actually equating the 0 of the transducer to the 0 millimeters of mercury for the patient. So zeroing is moving this transducer up and down till this orifice is connected to mid-chest level. The third one is calibration. We have to find out whether 100 millimeters of mercury is equivalent to, so this is basically an in the olden methods, pressure mercury manometer is connected and it is inflated to 100 millimeters, and you see whether the pressure trace will go to 100. But now today's machines are auto calibrated. So if you press an auto calibration machine button, immediately it gets calibrated. So mostly this balancing calibration is done simultaneously in one go, and zeroing is done by just adjusting the opening to the mid-chest level. The pressure measurement, for it to be very accurate, we need to have a short catheter, we need to have a large lumen catheter, we need to have a light fluid like saline, and we need to have a non-compliant rigid catheter. So it should not be a collapsible catheter, there should not be any blood, the catheter lumen should not be 3 French or 2 French, and it should be, the tubing should be shorter, it should not be a 500 centimeter long huge tube. What are the artifacts that are created? Tachycardia is one of the common cause of an artifact. This is a beautiful trace of a right atrium that is created at a heart rate of 60. When the heart rate is 60, the frequency of the heart is just 1 Hertz. The 10th harmonic of the heart's contraction is 10 Hertz. Many of the minor fluctuations such as dicrotic notch, end diastolic notch, C notch, everything can be picked up at 10th harmonic. So if you want a 10th harmonic, your natural frequency has to be 30 to 40 Hertz. Majority of our transducers that we'll use in the cath lab are 60 to 80 megahertz, 60 to 80 Hertz. So if the heart rate is between 60 to 120, we will get good trace. But let us assume what happens if the heart rate goes to 180. This is a fast atrial fibrillation, 180. You can appreciate the aortic pressure, only few beats are opening because the ventricle itself is not opening up the aortic valve. This we can understand. This is called pulse deficit. But atrial pressure is also not showing any trace at all. This is because the tachycardia is too fast. Ideally, the natural frequency for a 10th harmonic at a heart rate of 180 should be 90 to 120, but our machine is only 60 to 80, so it is not able to detect any pressure. So first artifact is tachycardia. Second is underdamping. Underdamping means too much of overshoots, peak of LV systole, everything, whatever is the peaks and troughs, they are overshot. Now, how to avoid overdamping? Greater fluid viscosity. So if suppose there is a small amount of contrast or blood, it will lead to overdamping. Small catheter radius will lead to overdamping. A bubble, clot, spasm, using multiple 3 ways. These are all causes of overdamping. So we should try to avoid over and underdamping. The third one is deterioration of frequency response. Over a period of time, the transducer loses its frequency response. Very often it is due to air leaks or due to blood and variety of things. Here, this is a pulmonary artery pressure. You can notice that there is too much of sharp fluctuations, which is completely atypical of a normal pulmonary artery trace. This is called as deterioration of frequency response, and this means the transducer needs to be changed. The next one is called a catheter whip artifact. It is the motion of the catheter within a cardiac chamber. A typical example is a pulmonary artery pressure that is put in with the Swan-Ganz catheter. You know that the Swan-Ganz will keep popping up and down. So this is the type of trace. Your systolic and your diastolic, there are so many traces. Ideally speaking, it should be like this, but there is too much of catheter whip, and each time the balloon floats towards or away, it produces too much of artifact. This is called catheter whip artifact. End pressure artifact. Whenever you are having an aortic stenosis, you make the catheter tip face towards that aortic valve. The forward flow will actually increase the pressure here. So in an aortic stenosis, an end hole catheter upstream, so it will increase the pressure. Now in a pulmonary stenosis, the catheter is actually downstream because the catheter, the jet is going this direction and the catheter is also facing the opposite. So pressure is reduced due to suction effect. This is called end pressure artifact. Catheter impact artifact. This is an example of a right atrial pressure, but the catheter has got lodged into the right atrial appendage. So each movement of the right atrial appendage is going to produce too much of fluctuations. This is called a catheter impact artifact. This can happen in valves like mitral valve. It can happen in papillary muscles as in left ventricle. It can happen in right atrial wall, right atrial appendage wall. It can happen on the right side due to moderator band. This is called catheter impact artifact. You have to free the tip of the catheter away. Peripheral systolic amplification, most of you will know, femoral artery will have a much more augmented pressure due to the reflected waves. And this is a peculiar phenomenon of aortic pressure as you move from central to periphery. Zero level error. You put a patient in a lying posture and you start recording the pressure. Suddenly the patient becomes pulmonary edema. You lift the patient with 4 or 5 pillows, but the transducer level is at a lower level. So the patient moves up and down, and this is called zero level error. What is balancing error? After a small period of time, we have already set the balancing in such a way that if there is no pressure at one end, the output will be zero. Now, but that keeps on drifting, and this zero drifting will need a rebalancing. So this is a zero drift that has happened, and then you rebalance and get it back to normal. Then calibration error. If you have the calibration to 100 millimeters of mercury or 200 millimeters of mercury is wrong, you will have the same vessel that is being connected. One vessel is showing much higher pressure and another vessel is showing much lower. So this calibration error has to be corrected by recalibrating the machine. And after the recalibration, you can now identify that there is left ventricle and right ventricle are more, the left ventricle in 2 transducers are more or less matching. So this is called calibration error. Entrapment artifact. If the catheter tip is caught inside a sac, this is a patient who has no aortic stenosis, only aortic regurgitation, but the catheter is trapped into one of the left ventricular trabeculae, and this is recording now a high pressure. If you pull it out, then it will become normal. Progressive flattening to sine wave. When there is a systolic, diastolic, there is no waveform at all. This is due to some thrombus, air, or something in the tips of the catheters. You flush it and you will get it back to normal. This is commonly seen in intensive care units. And the last one is related to physiology. You can have too much of fluctuations depending on the respiration of the patient. And whenever a patient is underhydrated, the fluid dependence of the hemodynamics is exaggerated. So this is an underhydrated patient where each of the breathing will be exaggerating the respiratory movement, because the limited amount of fluid that is present in the right atrium and right ventricle will be too much dependent on the respiratory variations. And so this is physiological variation. So this is how a pressure recording is being done and how to understand an abnormal pressure recording. The third one, now we are going into how to interpret different chamber pressures. This is an atrial pressure. Typically we have to see A, X, V, Y. And we need to understand that there will be an inspiratory increase and an expiratory reduction in all the intracardiac pressures. This is the normal. But mean, which is taken for an average of the entire page, may remain constant. If you put the mean as beat to beat mean, then you will have a mean also going up and down. And this will create a difficulty for us to find out what is the mean pressure. And hence, majority of the cath labs will use a mean, which is averaging the page, entire page. It's actually, the mean is an artificially created data, which is area under the curve. Now, we have to pay a very careful attention to all the waveforms. This is a patient with a mitral stenosis where we are finding a transmitral gradient, but the steep VY descent and the tall V wave will make us think that whether it is a mitral regurgitation. However, if you carefully see, the V to Y descent is much, much, much longer. The Y is almost happening just prior to the P wave. It is so late. So this means this particular patient is having tight mitral stenosis because the VY descent is very slow. On the contrary, this is an example of a mitral regurgitation where the VY descent, the Y is happening almost in the earlier part of the diastole itself. So VY descent. So each and every wave needs to be understood in these patients. Ventricle between right and the left ventricle. Left ventricle is more rectangular and right ventricle is more triangular. Even though the IVCT and IVRT of a right ventricle is smaller, the right ventricle will continue to keep on increasing the pressure till the mid of systole or late part of systole. That is the peculiarity of a right ventricle. Whereas left ventricle will reach its peak at the end of isovolemic contraction itself. And hence, throughout the systole, it is able to maintain a rectangular plateau. So rectangular pattern is LV, triangular pattern is RV. We also need to find out what is the end diastolic pressure and look at the waveform characteristics. In aorta, we have to understand that the initial upstroke is the percussion wave. The later part of the buildup of the aorta in systole is the tidal wave, then the dicrotic notch and the dicrotic wave. Both the dicrotic wave and the tidal waves are actually Madam, then I will stop here, madam, so that if there are any questions, then I will.
This is a very, very important and interesting topic for the residents, and I'm sure it would have really helped them to understand the basics. So I'm just wondering if there are any questions. I don't see any question on the.
I'll then go through the PowerPoint a little bit.
Yes.
So then if there are anything, you can stop me, madam.
Yes, please do that. Thank you.
So now, having understood what are the individual chamber pressures, now let us understand why we are doing catheterization in each and every individual lesions. In general, in a left-right shunt lesion, if we have to do a cath, it is for deciding the operability. A large proportion of this decision is taken based on symptoms. Very young age, we always assume that they are operable. Clinical findings of hyperkinetic circulation, cardiomegaly and plethora on the X-ray, appropriate chamber enlargement on the ECG, right ventricle for pre-tricuspid shunt and left ventricle for a post-tricuspid, volume overload and shunt pattern on the echocardiogram, pulse oximeter and oxygen saturation on exercises. However, there will be certain situations where you will be doing some catheterization. For example, ASD with significant pulmonary hypertension is seen in about 5 to 6% of the patients. By and large, they can be grouped into two groups. Number one group, genetically predisposed, younger patients, often the ASD is less than 2 centimeters, and these patients probably are on substrate of idiopathic PAH. The second group is progressive RV, larger and larger stroke volume leading to endothelial shear stretch and pulmonary vascular disease. Often here the ASD is more than 2 centimeters, and the patients are often in 4th or 5th decade. So based on their age, we may be able to understand. The criteria for operability in these patients will be a QP by QS of more than 1.5 with PVRI less than 6 and the PVR by SVR ratio less than 0.3. If you are using PA to aorta diastolic pressure ratio, it is less than 0.4. And whenever you are doing a vasodilator testing with any form, whatever it is, whether it is just an oxygen or oxygen with nitric oxide, then it is 20% reduction in PA mean, PVRI, PVR by SVR ratio. And the rule is there should not be any significant step down in the left atrium at all. Now coming to post-tricuspid shunts, if in a large, very large post-tricuspid shunt, ideally speaking, the aorta and pulmonary artery will be almost looking similar if the patient is having a significantly elevated PA pressures. However, when we are giving a vasodilator challenge like nitric oxide or like oxygen, the diastolic pressure in a VSD will keep on falling progressively low, thereby creating a diastolic separation. And this peculiarity is a feature of VSD. In order to understand it, in a VSD, left ventricle and right ventricle are freely communicating with each other, and the RV is communicating to PA and LV is communicating to aorta. So all the four pressures, systolic pressures, are exactly the same. So there will be systolic equal pressures throughout in a large ventricular septal defect. Whereas in a PDA, let us see what happens. PDA, ideally speaking, aorta, the aorta and pulmonary artery are totally in the same level. So ideally speaking, both the pressures should be similar. However, on oxygen or on nitric oxide, there is a left to right shunt that increases the PV return and increases the LA-LV filling, and the LV now ejects with a higher stroke volume. When there is a higher stroke volume, this is called as the impulse gradient. So there is an impulse that is transmitted suddenly into the aorta. So the aortic systolic pressure is higher. However, in diastole, since both of them are communicating with each other, both the pressures will fall back. So diastole will be equal in a PDA, large PDA, whereas diastole will separate in a large VSD, because in diastole, both the semilunar valves are closed. So the two pulmonary artery and the aorta are now left as two isolated circulations, and hence diastolic can fall. Of course, whenever you are doing a balloon occlusion, you will have a significant separation. The different time at which patients will present with Eisenmenger for different level of shunts will be in AP window and PDA, since the pulmonary artery is facing the systemic pressure both in systole and diastole throughout. There is more and more of shear stress and circumferential stretch, and hence there is too much of pulmonary hypertension, and hence they tend to present very, very early. Between AP window and PDA, AP window is like a window. There is no resistance across the flow through the window. So it often presents in very, very early, first decade itself, whereas PDA is like more like a tube. So it adds to some resistance, and so it goes to second decade. Whereas in VSD, the PA faces only systemic pressures, only in systole. So slightly the presentation is later, and ASD obviously will be much later. We have to understand, whenever we are catheterizing a patient for a shunt lesion, the confounders like airway obstruction, bronchopneumonia, reactive airway disease, bronchopulmonary dysplasia, anemia and polycythemia, hypothyroidism, B1 deficiency, chronic lung pathology, and all these are conditions that may alter the PVR, and hence we need to be aware about it. One of the pattern that is done in shunt assessment in PDA is a duct temporary occlusion, wherein you separate the aorta goes up, the pulmonary artery goes down. And if the patient is having a a stable rhythm, you will find that there is a bradycardia around this time. This is called as the Nicodolani-Branham effect. The heart rate slightly slows down when you are occluding the ductus. And you continue to occlude it for a short while, then there will be a wide separation. And this is also considered as a sign of operability. Down syndrome is a very peculiar situation. Often we'll be doing cardiac catheterization because of questionable operability. We have to understand that since Down syndrome has frequent respiratory tract infection, they have a reduced pulmonary vascular tree development. The large VSD on a small pulmonary vasculature will transmit the entire LV pressure onto the entire pulmonary vasculature. So they are more susceptible for PAH, airway hypoplasia, obstructive sleep apnea. Their vascular response itself, being a syndromic child, will be very abnormal. So they tend to develop pulmonary vascular. So I'm stopping here.
Yeah, maybe we can take those questions like.
Sure.
Thank you, Shiva.